Need for future care. This is the big one. Based on maximum MMI, maximum medical improvement, AMA guides to impairment, based considering the science of the 3 phases of healing, the patient's necessity for past palliative care, and the patient's aids. I was surprised last night in that talk that one attorney nailed it. I think it was an attorney that nailed it when I said the best, remember, you don't want it to be your opinion. So remember last night when I said, guess what the best indicator is for the need for future care? And an attorney actually answered it. He said, the patient's past care and what they needed. Because now it's not my opinion. That is exactly what that patient needed before they reached MMI. In other words, I'm treating them, and I went through a time period from one re-exam to the next. There was no improvement. But I knew the frequency of care they needed, and what type of care. Because that's what their treatment therapeutic protocol and frequency should have been based on. So I already have one cycle from one re-exam to the next that I'm at MMI, that I can feel comfortable calling it MMI. Usually I found I typically went to 2 cycles, 2 re-exam cycles. Because typically if I went through one cycle and there was no improvement, I typically changed something. You know, I tried another therapy, I'd try to change something. And so if I didn't see it again, well, I'm like at 2 re-exam cycles, and I'm in the repair phase. In other words, I'm in the later phases of healing. So now, it's not repair, remodel. So I'm in the remodel phase, and I'm through 2 repair cycles. How comfortable am I calling it MMI right now? I'm real comfortable. And now I know the frequency of that the patient needed some therapy to feel better, and I know what kind of therapy. Now you guys know this, because how many times you had a patient and they'll come in and go, oh doc, man, I could have used you last week. Well, guess what? Chances are your frequency is too far apart now. Right? So, by the way, it's the same thing. If the patient's doing good and they can go further, guess what I do with their frequency of care? I prolong it. I go, well, let's try to go 2 weeks this time. I only do that at the re-exams. I'll go, okay, you did good for a week. Well, let's try to go 2 weeks. Let's go every 2 weeks. Let's see how we do until the next re-exam every 2 weeks. And then they go 2 weeks, and then they go, oh, I could use it. I'm like, okay, you're about 2 weeks. So now I have a pattern of every 2 weeks, and they need, say, a chiropractic adjustment, and say they need some muscle stim to help help control some pain or some muscle, right? Now I know exactly what that patient needs for MMI the rest of their life. They need to get adjusted about every 2 weeks, and they need some type of pain modality. That's how. But here's my point. It's not based on my opinion. It's totally based on the patient. It's patient-centric and the experience of the patient. What really happened to that patient. That's what I'm basing the prognosis and need for future care on. So